take a moment to thank our esteemed moderators for today's session, Dr. Anita ma'am from Department of Biochemistry and Dr. Prerna Subhash Chandra ma'am from the Department of Neurology. Thank you so much for being here. We truly appreciate your time and guidance. We are excited to introduce our speakers for today's session, Sakshi Choradia and Rahul Vai, third year MBBS students, who will be presenting the research paper titled Blood Markers to Detect Alzheimer's Disease in Primary Care and Secondary Care. Let's look forward to an insightful and engaging session. Over to you, Sakshi and Rahul.
Good evening, everyone. Am I audible? Any response?
Yeah, you guys are audible. Carry on.
Hello again. Good evening, everyone. Today we will be presenting a recent paper published in JAMA in October 2024 titled Blood Biomarkers to Detect Alzheimer's Disease in Primary Care and Secondary Care. This study evaluates whether a simple blood test can accurately diagnose Alzheimer's disease in real-world clinical settings. The study is led by Palmquist and colleagues from Sweden. Now let's talk about this is the overview, what we're going to speak about. The journal, again, as I said, JMA, these are the important things mentioned here. It was published on July 28, 2024. Now, regarding the title, these were the authors. And the title, the first thing I would like to say is the title is clear and focused on clinical application, assist, and the diagnostic accuracy nature of the study. Now, let's go to the background and the need for study. Now, Alzheimer's disease is a commonly misdiagnosed, especially in primary care. The current confirmatory tests, such as lumbar puncture for CSF biomarkers or PET scans, are either invasive, expensive, or unavailable in many hospitals. With the new anti-amyloid drugs now approved, accurate biomarkers-based diagnosis is more important than ever. So the key clinical question is, can a blood test earlier and more easily? That is the need driving this study. Now, regarding the objectives, the main objective of the study was to prospectively evaluate a commercially available Alzheimer's disease blood test using predefined cutoff values in both primary and memory clinic settings. They tested two biomarkers, the percentage of plasma p-tau 217, APS2, a combined score using p-tau 217 and A-beta 42 and A-beta 40 ratio. They compared the performance of the blood test with the diagnostic accuracy of the clinicians themselves. Regarding the methodology part, Sakshi will be talking about that.
Thank you, Rahul. Coming to the methodology part, first we focus on the study design. So the study design for this paper that they chose was a prospective observational study, which is completely appropriate for the objectives. Because in this case, there was no intervention that they were testing, and they were only testing the diagnostic performance of certain blood biomarkers. And these biomarker assays, they cannot rely on old retrospective samples. And therefore, a prospective observational study was an appropriate choice. Coming to the ethical clearance, it was approved by the Swedish Ethical Review Authority. The study duration was, there were 4 cohorts, and each of them had their own study duration. The total study duration across all the cohorts was from January 2019 to January 2024. Coming to the study design, coming to the study place or setting, there were 2 settings. There was a primary care setting and a secondary care setting. The primary care setting included 17 primary care centers across southern Sweden, out of which 12 were public and 5 were private. The secondary care setting was from the memory clinic, which was also again based in Sweden. All of these sites were a part of the Biofinder studies, of which this study is also a part of. As we can see in the primary care settings, there was a huge diversity of the centers, which meant that the population was very diverse, and hence the results would be more generalizable. Coming to the studies, there are 100 studies that are registered on the clinicaltrial.gov website. Coming to the study sample, the primary care batch had 307 samples for the single batch analysis, and the prospective analysis had 208 samples. Secondary care had 300 and 398 samples respectively. So in total, there was 1,213 samples. But there was no formal sample size calculation present. So this raises the question whether this sample size was adequate. A lot of times in such studies wherein there's a validation of a predefined biomarker, the sample size is not calculated because the study relies on the patient inflow. And as we can see, the confidence intervals, as we'll see in the later slides, the confidence intervals were very narrow, which indicates that the sample size was more than enough. So in such studies, a sample size calculation needn't be present. Coming to the study sample, the possible confounders, there was no formal, has minimized a lot of confounders to a large extent because the primary care centers were so diverse. The population variety, there was a good amount of population variety. And coming to the sample demographics, they have mentioned that in the results, which we'll see in a bit. Informed written consent was obtained from each and every participant who also participated in this study. Coming to the inclusion criteria, there were clearly defined inclusion criteria given in the paper, which were also appropriate for study objectives. The inclusion criteria included adults undergoing evaluation for cognitive symptoms, recruited from defined clinical settings, had plasma samples available, had a valid reference standard for Alzheimer's pathology, and they provided informed consent. Coming to the exclusion criteria, they were not clearly defined in the paper, but rather they were implicit. So the exclusion criteria included missing blood biomarkers, missing reference standard, major neurological conditions interfering with biomarker interpretation, non-standardized sampling or processing, and refusal or inability to consent. Coming to the protocol that was followed, the study followed the stroke guidelines. At first, the patients presenting with cognitive symptoms were included in the study. So the cognitive symptoms could be memory complaints or suspected dementia. Of these patients, there was consecutive recruitment followed, which reduced sampling bias. And there were 17 primary care centers and 2 secondary care memory clinics. And there was no advertising, only real-world referrals were included. Of these patients, initial clinical workup was done, where the diagnostician or the doctor was blinded to the biomarkers. A detailed history was taken, and differential diagnosis were considered. After this, a clinical classification was made, and this was made before seeing the biomarker results. So the clinical classification included subjective cognitive decline, mild cognitive impairment, and dementia. The dementia included all the possible causes of dementia. And the reason why this was done before biomarker results was so that they can prevent incorporation bias and they can also ensure objectivity. After this, a blood sample was collected from every single patient, and this blood sample was a venous blood, and it was collected in the EDTA tubes, and the tubes were kept on ice immediately, and they were processed within 30 to 60 minutes. The plasma processing and storage, this was a very detailed area of the paper, and this because this was such a detailed area, the pre-analytical processing was very detailed, which is a very excellent strength of the study. Coming to the biomarker measurements, plasma A beta 42 concentration and A beta 40 concentrations were measured, and they were used to calculate the ratio of these two proteins. And plasma P tau 21 P phosphorylated tau 217 concentration was also measured. And then the percentage of this protein was calculated. Coming to the analysis workflows, there were two analyses. One was a single batch analysis, and the second one was a prospective real world analysis. This single batch analysis was where all the samples were analyzed together and there was no batch variation. This is an ideal setting. But in the real world, not all samples are usually analyzed together. In the real world, normally the labs will run small batches which are analyzed every 2 weeks. So the prospective real world analysis mimics actual clinical laboratory workflow. And a lot of validation studies don't normally do the prospective real world analysis. And because this study has done this, this also contributes to the strength of the study. Coming to the computation of APS2 score, so APS2 was calculated using a logistic regression model, and this score combined two separate biomarkers. So the p-tau217 percentage as well as the A-beta 42 is to A-beta 40 ratio. Both of these were combined to give the APS2 scores, and this score ranged from 0 to 100. And the score basically says the probability of amyloid deposition. And the cutoffs used, there were two cutoff models that were used. One was a single cutoff and the second one was a two cutoff model. So in the single cutoff there was a 90% specificity cutoff, and in the two cutoff model there was a 95% sensitivity and 95% specificity cutoff. So the single cutoff model has only a single cutoff, but then the two cutoff model, it's like when we are writing an exam, above 90% is 100% pass, and below 40 is 100% fail. So it's like that. So there are two cutoffs, and whoever gets a score between 90 and 40, they get considered in the gray zone. That is how the two cutoff model works, and this is a very good model because it ensures a larger margin of clinical safety. Coming to the next step, which was the gold standard of AD pathology status, which was given from the CSF or the PET scans. A participant is Alzheimer disease positive if if the CSF ratio was less than 0.072, and if the p-tau217 was more than 11.42 picograms per milliliter, or the amyloid PET scan is positive. This is a guideline which is standardized across the world, and the CSF was collected via the lumbar puncture, stored at negative 80 degrees Celsius, and analyzed on automated immunoassay platforms. And if the CSF was unavailable due to a variety of reasons, like if the lumbar puncture was not done, then a PET scan was used. Coming to the diagnostic accuracy analysis, they measured the following items: sensitivity, specificity, positive predictive value, negative predictive value, and the overall accuracy. Along with this, they also did the ROC curves and the area under the curve values. DLong test was done for comparing the area under the curves, and bootstrap resampling, which is 5,000 iterations for confidence intervals. So bootstrap resampling is when the computer regenerates many sets of data from your given set of data. So for example, if you have the marks of all the students in a class and you want to find the true average of those marks, you can give that set of data to a computer, and the computer will generate similar such data sets by choosing random values from the original data set. And these values will be completely random. So in this way, you can get many different data sets, and you can calculate an average of all of these data sets, and then you'll get a range in which these averages fall. So that is how you get the confidence interval. So a bootstrap resampling basically ensures that your confidence interval is as accurate as possible, and the average that you have found is the true average. It reduces bias. Coming to the comparison against clinician performance, the primary care physician's diagnosis versus APS2 and the dementia specialist diagnosis versus APS2 in the secondary care centers was done. And this is the most important part of this entire paper, because this is where we can see in the real world where the physicians are diagnosing Alzheimer's disease and how these blood biomarkers are faring against the physician's diagnosis. And finally, the result that we found from this very important category was that the blood biomarkers significantly outperformed the clinicians. Coming to the variables, so there were certain independent variables and certain dependent variables. The independent variables were all the biomarkers, And the dependent variable was the Alzheimer disease pathology status, because the pathology status was dependent on how these biomarkers are faring. And a continuous variable is when a particular variable can have infinite values. It doesn't necessarily have a certain set of values. So, for example, a plasma p-tau 217 concentration can have infinite values. It can range all the way from 0 to the maximum amount. So it can have an infinite value. So it's a continuous variable. Same goes for all the biomarkers. Coming to the Alzheimer disease pathology status, it is either yes or no. It is either positive or negative. So it is considered a binary variable. A dependent variable is always the outcome or the reference standard, and the independent variable are the index tests. Coming to the analysis, the software used was the R, which was of the version 4.3, which is a standard software and a model. And ROC based diagnostic accuracy statistics were done. Area under the curve, sensitivity, specificity, PPV, NPV was done. Along with that, DLong tests and bootstrap resampling was done. Analysis was stratified by primary versus secondary care and by single batch versus prospective biweekly batches. All of these are relevant comparisons, and they're also relevant to the objectives which were defined at the beginning of the study. And clinician accuracy was also compared using the same metrics. A p-value of less than 0.05 was fixed as significant, which is an acceptable significance level. Coming to the comments on the methodology, correct references were provided wherever it was required. Instruments and protocols that were used were standardized and validated. For example, the category to classify Alzheimer's disease as positive and negative, and consecutive real-world recruitment was done, and very strong lab methodology. As we saw, the blood collection as well as the blood storage policies were very strong, and they were already predefined. And there was excellent statistical rigor, mainly because of the bootstrap resampling, which in this case, it was done 5,000 times. So they generated 5,000 different data sets and found an average for each data set. And then with those averages, they calculated the range, which was a confidence interval. Because it was done 5,000 number of times, that gives an excellent statistical rigor. Coming to the negatives about the methodology, the first one is that this is a cross-sectional design. Because this is a cross-sectional design, we can't say whether the blood biomarkers also can predict how the disease is going to progress. And there was no multivariable adjustment done between the ages of all the patients or their APOE scores. And there was missing CSF and PET, which led to automatic exclusion. So in this study, only those patients were included who had undergone a CSF analysis or a PET scan. Those patients who did not undergo these tests were excluded. A lot of times, patients who undergo these tests already have a very severe stage of the disease. So it could be that the biomarkers were able to pick up a severe stage rather than the people who could not undergo these tests. Recruitment was limited to people already in the memory evaluation, and no reproducibility assessment was done. Coming to the results part, this was the first table given in the paper, and this is the characteristics of the primary and secondary care cohorts. The median age is 74 years across both the primary as well as the secondary cohort, and there was a slight female preponderance which was seen. Coming to the first figure, here we can see the performance comparison of the blood tests using the one cutoff value approach along with the presence of Alzheimer's disease pathology as an outcome. So here, the yellow marks are the APS2 and the blue marks are the percentage of p-tau 217. So as we can see, in the secondary care where the single batch analysis, the p-tau 217 had a very high accuracy as well as a very high specificity and sensitivity. But the same thing when we see in the primary care, APS2 has increased and p-tau 217 has decreased. This can be because in a secondary care, the patients already have a much more advanced level of the disease than in the primary care. So maybe because of that, p-tau 217 was able to better pick up the disease than APS2. But in a primary care where the disease may not have progressed as much, APS2 was able to pick it better than p-tau217. Coming to the prospective analysis of secondary and primary care, we can see that the results are somewhat similar. The ranges are somewhat similar, which means that the biomarker was performing in a similar manner in both the care centers, which also goes to say that in a real world, the biomarker is generalizable across all the care centers. Coming to the cross tabulation analysis, this is a 2 by 2 table. This is a 2 by 2 table wherein there are 4 boxes as shown. The top left box over here is negative and negative. So this is the true negatives. And the top right box over here shows the false positives. And the bottom left box over here shows the false negatives. And the bottom right box shows the true positives. So whenever we read a cross tabulation analysis, we need to make sure that the true positives and negatives have a higher number than the false positives and negatives. As we can see in all of these cross tabulations, these two, like where my cursor is pointing right now, these two numbers are lesser or they are smaller when compared to these two numbers, which basically means that the true negatives and the true positives were a higher number when compared to the false negatives and the false positives. If there's a higher number of true negatives and true positives, it means that the specificity and sensitivity of a particular test is higher. If there are more number of falses, then that reduces the specificity as well as the sensitivity. More number of false positive reduces the specificity, and more number of false negatives reduces the sensitivity. A specificity of a test is basically how sure can the test rule in a particular disease. And a sensitivity of a test is when how surely can a test rule out a disease. So as we can see, the sensitivity and specificity of APS2 as well as p-tau217 is quite high. These cross-tabulation analysis tables can be used to calculate the sensitivity and specificity. Coming to the prospective analysis, secondary care and primary care. In all of these, because these are prospective analysis, which is they were done with every every bi-weekly, they were done. So we can see there are certain intermediate results which are given. Now these intermediate results are when the test was not able to clearly say whether a person has Alzheimer's disease or the person doesn't have Alzheimer's disease. The intermediate results percentage is higher for APS2 and lesser for p-tau217 across all the different care centers. This is because APS2 basically is not a biomarker. APS2 is a combination of two different biomarkers. So if the result of both the biomarkers do not agree, there is a mismatch, and therefore APS2 will show it up as a gray area. But in p-tau217, since it's a single biomarker, if the result is a complete positive, it shows it as a complete positive. Basically, the APS2, because it's a two different biomarkers, it has a higher degree of clinical safety. And APS2 is more reliable in the real world because of its higher degree of clinical safety. And therefore, it also gives a higher value, a higher percentage of intermediate results. Now, these intermediate results, the patients who fall into these intermediate results are those who will have to undergo a CSF analysis or a PET scan in order to completely rule out the Alzheimer's disease pathology. This basically means that though these blood biomarkers are very powerful, they cannot completely replace the CSF analysis as well as the Alzheimer's disease, as well as the PET scans. This is the cross-tabulation analysis for these graphs itself. Again, as you can see, the intermediate numbers over here for APS2 are higher than p-tau217. Now, this graph is the most important one in this entire paper because this is where they have analyzed the dementia specialist and as well as the primary care physician's ability to diagnose Alzheimer's disease along with the blood biomarkers. So as we can see in the graph A, where it is about a secondary care, so here the blue marks show a dementia specialist. As we can see, both APS2 and p-tau217 can have a wide margin and they can overcome the dementia specialist diagnosis. Same goes for a primary care physician, but the margin over here is even more wider. So as we can see, by implying these blood biomarkers, we can give a higher surety of diagnosis to the patients. And this is a cross-tabulation analysis for the same graphs. This is where in the beginning, as we discussed, even before the blood biomarkers were done, the physician had classified the patients into three different categories. One was a subjective cognitive decline, one was a mild cognitive impairment, and the third one was dementia. So they have also seen how these tests have performed in relation to the three classes. So as we can see, there's a higher confidence margin, higher confidence interval of positive predictive value as well as sensitivity in subjective cognitive decline. But in mild cognitive impairment and dementia, the results all fall under approximately the same confidence intervals. And below over here, these are the cross-tabulation analysis of the same. So this basically means that in a subjective cognitive decline, there's a higher chance of getting a false negative, which basically means that if the person has a subjective cognitive decline, it could be a lesser severe disease of a lesser severe stage of Alzheimer's, which leads to a higher degree of false negatives. This is the biweekly analysis done for these three groups itself. Again, we can see the intermediate results over here. They are higher for APS2 than for p-tau217 because of the same reason as discussed before, since APS2 is a combination of two different biomarkers. And below given over here are the cross-tabulation analysis for the same. Now, these are the ROC curves. ROC curve is plotted for a particular test, and ROC curve basically says the sensitivity and specificity for every single cutoff possible. Now, for these particular biomarkers, predefined cutoff values were used. But if a particular diagnostic test does not have predefined cutoff values, then an ROC curve can be plotted to show the sensitivity and specificity for every single cutoff value possible. So in an ROC curve, the area under the curve says how good the test is. If the area under the curve is completely 1, so the curve would be vertical touching 1, and then it would be completely horizontal. It would be like a right angled, it would be like a right angle. And that means that the test is completely perfect. But in a real world, in an ideal world, a test can be perfect. But in a real world, there's always a certain margin of error that is present in every single test. So we can see that. So we can say that an area under the curve more than 0.9 means that the particular test is an excellent test. But here we can see that the area under the curve, especially for APS2, is consistently 0.97 and 0.96. So it's more than 0.95 in all the settings in biweekly analysis or in a single batch analysis, which basically means that the test is consistent across every single setting, which is a very big strength of the test. Coming to the comments of the result section, the gray zone approach reduces misclassification. So because of the gray zone approach, we have a wide margin of clinical safety. So it either tells completely that a person has Alzheimer's disease, or it tells that the person does not have Alzheimer's disease. And because of that, we can reduce misclassification and we can reduce overfitting of the results. And there is consistency across the subgroups, as we discussed in the previous slide. There is a area under the curve 0.96 or 0.97 across all the different settings. Coming to some of the drawbacks of the results, because of this gray zone proportion, even though it reduces misclassification and it is a strength, there is still some uncertainty in the gray zone proportion, because these patients have to undergo a CSF analysis or a PET scan in order to completely rule out or rule in the Alzheimer's disease. And the prevalence of Alzheimer's disease in the sample is high because the sample was only the patients who were coming to the memory clinic. The prevalence of Alzheimer's disease in the sample is high. The cohort had a relatively well-educated participants. Now, this can lead to the cognitive. A well-educated patient, a well-educated participant will have a higher cognitive ability than a non-well-educated participant, and this could also falsely inflate the results. And because there is lack of data on comorbidities affecting biomarkers. Now, since both these biomarkers, A beta 40, A beta 42, and p tau 217, all of these are proteins, a lot of different comorbidities like liver diseases or renal pathologies where there is or reduced clearance of the protein, they could lead to a difference in how the test picks up these biomarkers. So, because there was lack of data on these comorbidities, this reduces the generalizability in the majority of the population where such comorbidities are present. Coming to the discussion section, the APS2 blood biomarker panel, which was combining the different biomarkers, it has excellent diagnostic accuracy. As we saw, the area under the curve was 0.96 or above, and 0.9 or above is considered excellent. So 0.96 or above is near perfect. And this was for detecting Alzheimer's pathology as confirmed by CSF or PET scan. And it worked consistently well in both the primary care as well as the specialized memory clinics. It also performed similarly whether it was a single batch analysis or a biweekly prospective run. Now, coming to the future directions. Because we said that the study was a cross sectional study and it cannot predict how the disease will progress in the future, a longitudinal study is better recommended, or it can be the next step in order to continue this research, wherein we can see how the biomarker can also predict the progression of the disease and validation in diverse populations. Since this study was only conducted in Sweden, the study was mainly focused on the Swedish population. The study needs to be done in a diverse set of populations for better validation. And a head to head with other biomarkers should also be done, especially the GFAP, which is the glial fibrillary acidic protein, which is an up and coming biomarker. So, a head to head with other biomarkers should also be done in order to detect, in order to see how well it can perform, and real world cost effectiveness studies. For in order to find the levels of all of these biomarkers, mass spectrometry was used. Mass spectrometry is a very expensive form of laboratory study, and it is not widely present, especially in low and middle income countries. And inter-lab reproducibility studies should also be performed. All of this analysis was performed at a single lab. 2 to 3 different labs should be used to perform these analysis to show the reproducibility between different labs. Over to Rahul.
Thank you, Sakshi. And in the conclusion part, to conclude this blood biomarker test, particularly APS2 and p-tau 217%, shows high diagnostic accuracy in both primary and secondary care settings and could greatly improve early detection and triage of Alzheimer's disease. However, further work is needed to validate these tests globally and to assess how they impact clinical outcomes in healthcare systems. Now, regarding the implications part, uh, our take home message, the blood biomarkers are rapidly transforming Alzheimer's diagnosis. The study suggests that a simple blood test could one day guide referral decisions, reduce misdiagnosis, and expand access to diseases modifying therapies, especially in primary care. Regarding the strength part of this particular paper, the study had several strengths. It was a prospective design with real world patients. It included both primary care and specialist settings. It used pre established cutoffs to avoid bias, directly compared performance against clinicians' diagnosis, and biomarkers analysis was blinded. Regarding the limitations part, however, there is an important limitation. The entire study population was Swedish, and performance in other countries may differ. The assay used high end mass spectrometry, which is costly and need expertise, as Sakshi mentioned earlier. They did not fully compare the percent p tau 217 versus p tau 217 absolute value. The study did not measure treatment outcomes or cost effectiveness, only the diagnostic accuracy. Now, Regarding the summary, why the study? The CESF PET biomarkers are accurate but invasive, costly and limited to tertiary care. Need for accessible AD testing in primary care. What did they test? The blood biomarkers, percentage of plasma p-tau 270, APS2, p-tau 217% plus A beta 42 is to A beta 40 ratio. Design and settings, a prospective diagnostic accuracy study of 4 real-world cohorts, primary, secondary care, and single batch plus biweekly. Population N is equal to 1,213 symptomatic patients. Regarding the continuation of the summary, the main findings were high diagnostic accuracy in all the cohorts, 88 to 92%. Area under the curve was around 0.96 to 0.97, and it outperformed the clinicians, ECP 61 to 91 with APS2, specialists 73 to 91% with APS2. The percent p-tau 217 was almost equal to APS2 in performance. Conclusions were the blood biomarkers can accurately detect AD pathology and improve diagnosis in both primary and secondary care. Like I would like to conclude telling that, and like let's start a discussion. I'd like to ask, if this blood test becomes widely available in India, how could it change our current approach to patients with early cognitive symptoms? Thank you.
Thank you, Sakshi and Rahul, for
Just a
that
second.
informative presentation.
I'm so sorry to interrupt you, Vashini. Just another point. I had actually missed in the actual presentation about the blinding. The lab analysis, the lab experts were blinded to the diagnosis made by the doctors, and the doctors were also blinded to the blood biomarker results. Because there was blinding seen on both the sides, this leads to a better rigor in the methodology and hence better results.
Thank you, Sakshi, for adding that. And thank you, Sakshi and Rahul, for that informative presentation. To add to the discussion, I'd now like to invite Dr. Anita ma'am to share her thoughts.
Yeah, good evening, students. Actually, it was indeed a very nice presentation. Topic chosen, then whatever, everything was neatly presented about the journal, then results discussion was neatly explained indeed about the outcomes. Everything was very well presented. Actually, this Alzheimer's disease is now the upcoming topic. That's what I really liked about this topic, and so much vast information that is being given. Mass spectrometry, I was really wondering, like you kids presenting about this. This is actually a PG level topic. Whatever you all have presented, I really would like to appreciate for selecting this journal as well as the topic. And one thing I would like to add to this is a little bit even more about the whatever the age presentation was okay, but whatever the discussion was done, the study was done only with the affected individuals, and the same levels I felt should have been done even with in the normal individuals, age and sex matched. So we would have got a better idea. That's what I felt. To prove whether these levels will be raised, increased, of course, PET scan will be done definitely. So what I felt was that should have been, that of course will be coming for the limitation of the study.
Topic, because we have targeted therapies now. We have monoclonal antibodies that target amyloid plaques. But what I wanted to ask you was whether you've read anything that tells you what the plaque burden in the brain is based on these biomarkers, because we are when we diagnose these patients, right, the whole point of having more accurate diagnostic testing would be to facilitate better treatment, right? You want to be able to treat this patient better, you want to be able to use whatever drugs you have in your arsenal to get make the patient be better, right? But when your clinical diagnosis itself is quite the ATN model, what we use now, which is, the plaque is assessed using your PET MRI and PET CT, whatever is available. And you see the amyloid plaques and you see the tau proteins. You essentially you see what the amyloid and tau depositions are like using PET, and then you do the neurodegenerate. The end part of the ATN model is neurodegeneration, which you do using a structural MRI. You see whether there is, the characteristic features of Alzheimer's disease, which will be temporal volume loss as well as posterior parietal, if I'm not wrong, part of the brain, which will be atrophied. So when these are quite useful, to diagnose the disease. Now, the problem comes when someone has mild cognitive impairment. So what I would have wanted to see in this study was if this is accurate enough in patients with mild cognitive impairment, because anybody can tell when it's an advanced Alzheimer's case that this is Alzheimer's, right? So whether there would be studies like that, A. Two would be, will this test give me anything more clinically to use to select a patient to uh, give them drugs, right? Because if I see the amyloid burden in the brain using PET, that should be that is generally enough for me to make a decision about whether they will be suitable candidates for monoclonal antibodies, right? So whether this will give me anything more that will be valuable to make this decision, well, that is one more thing. And the third thing I want to point out is whether these tests can be used to prognosticate, right? So whether once we've started a patient on one of these drugs, donanemab, I think that's one of these drugs, aducanumab, that got into a lot of controversy actually. So whether these can be used to prognosticate. Of course, it's all in the early stages. And here in NIMANS, we use CSF tau, which was started like last month actually. CSF tau is what we use. But although most of our professors here prefer, PET showing, functional like FTG PET or structural MRI or, amyloid PET. So, yeah. And as for GFAP, I think Sakshi also brought up like an emerging biomarker being GFAP, which is a blood-based biomarker actually. And GFAP is very non-specific. So GFAP can be elevated in many neurodegenerative conditions and mimics of Alzheimer's as well. So you have like frontotemporal can look like Alzheimer's. So it can be elevated in these as well. So that is what I wanted to say.
Ma'am, actually, at the moment, from what we understood by reading the paper, it's like APS2 is more like a binary indicator kind of like it just tells whether a person has Alzheimer's disease or the person doesn't have Alzheimer's. Like it can't predict the plaque burden on the brain as you mentioned. So maybe it's more like if a person has Alzheimer's disease, whether it's if it's confirmed by the APS2, then they can undergo a PET and then they can find the plaque burden and they can tailor the treatment accordingly. Uh, yes, ma'am. At the moment, APS2 can't tell the plaque burden.
No, but
And
that's the thing, right? It's a binary test. Uh, you get a patient with age 60 and above coming with all these symptoms that are consistent with Alzheimer's disease, right? What additional thing will your APS give me that a PET MR or a functional PET like FTG PET or an amyloid PET won't give me now? So that is what needs to be done, right?
yes, ma'am.
It,
Yes, ma'am.
it's not just that it aligns that, oh, we know that this is elevated. The diagnose, if a physician is able to already diagnose this condition, uh, what is the use of having this biomarker? Like, that will be the primary question, right? I mean, obviously, like, I'm sure, moving forward, we'll find, reasons to use this test will emerge, right? This is how all biomarkers started off. There was a huge question of why do we need this? I'm sure we'll find uses for it, but right now that is what I was thinking, now seeing the paper.
Yes, ma'am. Another thing is like a CSF analysis would require the patient to undergo a lumbar puncture. Maybe in places or in situations where the patient is unable to go and undergo an LP, a blood test is like it's a far less invasive procedure than an LP. So maybe it can like act as a stepping, like maybe it can just tell us whether the person has Alzheimer's disease or it doesn't. But yes, ma'am, I agree. Future studies should look into this.
Yeah.
Actually, these kind of tests, if it is in the initial stages, it will be better prognostic. See, whatever the blood tests and the CSF analysis, like if we are doing and if it is cost effective compared to MRI, but I think mass spectro is
Yes,
comparatively
ma'am.
It will come, I think
expensive.
prices will become the same, like whether they
Yes,
do
ma'am.
mass spectrometry or PET. But one more thing, Sakshi, nowhere in this paper have they mentioned any, like the cognitive assessment scales that they've used and
No, ma'am.
like what stage of the disease the patients were in, right? Like that is one more thing, like that will affect, right? Like we ma'am also said, right? Earlier stages, mild cognitive impairment is where the doubts come. Like
Yes,
what is the
ma'am.
phenotype of this patient, right? So
Yes, ma'am.
a person just coming with amnesic dementia, like amnesic dementia is when you mostly have memory related issues. Um, all these other features of Alzheimer's, your visuospatial and executive dysfunction, these come up much later, right? Like how this is where it is, right? The MCI spectrum of people are where this needs to be focused, and this paper doesn't tell you anything about how accurate it was at diagnosing Alzheimer's in this particular group of people. I think that would have been very useful. I mean, I think they could have done it very easily analyzing the data that they got from this set of people would have been easily interpretable, right? Like they already have the data. I'm
Just,
guessing they already have like a bunch of people, right, that they've uh, worked up for Alzheimer's. They've already have the clinical like cognition scales that have been applied to these patients. They have a bunch of set of people who have mild cognitive impairment who they have
yes,
confirmed the diagnosis through other means, say PET or whatever.
yes, yes,
Um,
ma'am.
wha- a separate analysis of this group of patients would have been so much more useful coming from this paper, don't you think? Like, at
Yes, ma'am.
least for me, that is what is going on in my head. Like, a very clear phenotype clinically, I would not want to subject my patients to an expensive test again. I would rather spend that money on a PET that shows me the plaque burden. You know what I mean?
Yes, ma'am. They have done it, but it's not done it in as much detail as like it's not that detailed.
Mm. So the gray zone remains a gray zone. Also, we don't know whether in mild cognitive impairment this uh, blood biomarkers will again fall into the gray zone that they've used a 2 point cutoff, right?
Yes, ma'am.
Again, we don't know whether this will again fall into that gray zone in patients with mild cognitive impairment who are already clinically in a gray zone, right? So that is
And
my
another thing, ma'am,
reasoning at least.
when you mentioned about it being used as a prognostic marker, ma'am, that's what we were also thinking. If like the next study should be like a longitudinal study, so that we can see whether the biomarker can predict how the disease will.
100%, 100%. And like you said, there might be interperson. Uh, See, what if these biomarkers also behave, like you said, with like large proteins, right? Like the
Yes,
excretion and things like that. And there are also other proteins, like last week we spoke about CJD. The 1433 level does not correspond with severity of the disease, right? So we don't know. So, like, yeah, this biomarker, whether it will be useful in a clinical setting or not. Of course, if it is in a setting where PET is not a thing that is available, and you have a patient with MCI, and we're able to prove that this biomarker is able to reliably tell you that this is rule out or rule in Alzheimer's, that will be wonderful, right? Blood tests are a lot more easily done, and blood can be transported. Blood, from one center to the other can be transported. So I think that is also one. That is a good thing. I think that is why these kind of studies are very important. Although this study, I feel, has some limitations. So, yeah.
Yes, ma'am. Ma'am, but then in this study, like they've used mass spectrometry. So if a center doesn't have PET, then it's doubtful that the center will also have mass spectrometry. So until and unless they can
No,
finally
no, I
do.
meant, see, transporting the patient to get PET-MR somewhere is difficult. But
Yes.
drawing their blood and sending the blood through mail, see, that now that can be done. That is what we do, right? Like, there are some tests that are not done in our center. So, Amrita Lab, Amrita Institute, they have a lot of fancy tests that they do. We just draw the blood here and we ship it there and they ship back the report. So, things like that is a way to look at it. So yeah, I think that is one huge benefit of studying blood-based biomarkers, the accessibility of it as compared to imaging. Yeah.
Thank you, Prerna ma'am and Anita ma'am. Now I'd like to invite Dr. Suraj sir to share his views.
Hello, good evening, everybody. The presentation was wonderful. The analysis, interpretation, all of it. I know that you guys have understood whatever you talked about. Ma'am, about the MCI batch having prognostic value, not prognostic, diagnostic value itself. I think they had that component also. They did show that the MCI, mild cognitive impairment group, did have good sensitivity and specificity with the tests that they did. So they could probably do what you said, ma'am. Like they could draw the blood, send it, and it would indicate whether they should they have Alzheimer's or not. So that I think it can be used in these kinds of places where they don't have imaging at all.
Yeah, like Dr. Suraj, like that part I might have missed, but this is the like these group of people who have mild cognitive impairment, those are the target group for like as a clinician, like we'll see Alzheimer's. For that is the group that you want to target because all of these disease modifying agents that we have now, they only work with patients with MCI. Advanced Alzheimer's, there is no drug that exists to reverse what has already taken place. So yeah.
Right, ma'am. Right. Exactly, but they did not tell us the cognition scales and all of that. So we don't know the cognitive profile of all of the patients, but we do know that even if they have mild cognitive impairment and they undergo this test, we can reliably identify whether they have Alzheimer's or not. So that definitely I think the study told.
Yeah, I wish they'd put this cognitive profile of the patients and also the subtypes. And one more thing is if I'm not wrong, the R4 tauopathy, right, Alzheimer's, I think a lot of other diseases also have elevated tau. I think this one, chronic trauma-related dementia and uh, FTD-PSP might also have elevated tau. I'm not quite
Yes,
sure
ma'am.
about the subtype, but yeah.
In the end, like when they had shown the analysis between SCD and mild cognitive impairment as well as dementia, there was a line in the paper saying that dementia due to all causes. So all the differentials that can cause dementia, they were seeing how p-tau 217 will act in all of these differentials.
Then it will become a non-specific kind of marker, right? It will become like GFAP again. GFAP
Yes,
2
ma'am.
shows it's non-specific marker of neurodegenerative. All tauopathies might. There are some different subtypes. There 4R, 3R. I'm not quite too well versed with it, but there are some subtypes, and this tau, the specific tau that is involved with Alzheimer's, is also involved with the chronic trauma-related dementias, PSP, and all of these. Um, so that is one thing, which is why a low bar function test like the cognitive profile, like Suraj had said, would have been very useful, right? So you can tell like Alzheimer's mainly shows you like visuospatial and executive and episodic memory dysfunction. So if we had a good clinical profiling of these cases, we can see how this particular blood marker behaves rather than having a blanket all cause dementia sort of thing. So yeah.
Actually, I would like to tell whatever the marker chosen, like sensitivity, specificity, whatever it is, it should be in the initial stages. Like comparing with the clinical symptoms, like initial mild cognitive symptoms should correlate with the levels of whatever the test we are choosing. That is the most significance of the blood biomarkers, like any cancer biomarker, or whenever a person has MI, we have the cutoff values for troponin I. So similarly, this also should be there. But the thing is now, since it is the upcoming topic, it is very difficult to set a cutoff value for dementia. Since it is a neurological disorder, it is not like, okay, this much is the value, this will be the disease progression. No, it is not like that. It varies from person to person, and from age to age difference also will be there. So I think really large population should be considered to set the cutoff values. That is my opinion in
Exactly,
general.
ma'am. Like even that's what I was thinking. Even in patients who have, senile related senile tauopathies as well,
Yeah,
right? No, age, and la again, you're saying this is from a particular ethnic group. Moving forward, a
exactly,
large ethnic
exactly.
group, different age ranges, different cognitive profiles need to be studied, I think. Like, and subtypes of Alzheimer's. Alzheimer's itself has many subtypes. So there is a more visuospatial predominant sort of Alzheimer's. There's an episodic memory predominant sort of Alzheimer's. Fast progression with early myoclonus sort of Alzheimer's. So all of these, again, a lot of scope though. Paper for a preliminary sort of thing. It's quite nice, honestly. And like Sakshi said, I think one of the biggest uh, strengths of this paper is the how they've sampled it. What's it called? Um,
Bootstrapping. The
yeah,
bootstrapping.
bootstrapping. Uh, that is I think gives it a lot of statistical rigor, even though the clinical profiling itself might be a little shaky. So yeah.
We could consider this like as a preliminary study because this has had like a very positive result. It could be considered like as a stepping stone, or like it has opened a door to a variety of different studies we could do on the same biomarkers.
Oh, 100%. The fact that we have technology that can reliably and we have mass spectrometry that can reliably estimate tau itself, that is a huge part, right? Like moving forward, like doing more studies, of course, very helpful. Yeah.
Actually, Rahul and Sakshi all have really done a good job. Very nice presentation. Whatever the steps you all have taken up, like stroke classification, about the journal, implications, everything presented very accurately. And especially that methodology part, you all have put it in a flowchart. I really like that. It is so simple, and the moment we see that presentation, no, like anyone can just understand that. It's very nice, actually. A very good job.
Thank you, ma'am.
I agree. You guys have done a really good job. Well chosen topic also. Um, Lots of clinical implications, very real world kind of paper, and you guys have done a good job. You've really understood your, content that you've put out, and
Exactly.
yeah, good job, guys. Very good job. Very impressed. Third years, huh?
Yes, ma'am. Yes.
Oh my
Exactly.
God.
Especially that results, even that results charts, very well you have explained, Sakshi.
In third year, I was
Very nice.
almost flunking comment. You guys are too good. Too good.
Thank you.
Now we'd like to hear from the audience. If you have any questions or thoughts, feel free to unmute yourself or type them in the chat.
If everything is done, can we wind up?
If there are no further questions, let me take a moment to thank everyone. Your participation truly enriches sessions like this. A big, yes, ma'am. A big thank you once again to Anita ma'am, Dr. Prerna ma'am, and Dr. Suraj sir for being. Let's continue learning and growing together to our journal club meets. Thank you once again for joining us today. Have a wonderful evening.